Good morning, everyone. It's a privilege to be here in Kenya today to speak about new prevention regimens and how do they affect HIV care. I have no conflict of interest. So in 2015, WHO recommended offering oral PrEP containing tenofovir to those who are at substantial risk of HIV for HIV prevention. Since the introduction of PrEP, there has been a cumulative number of 5.6 million initiations globally. However, most of these PrEP initiations are concentrated in fairly small numbers of countries, including South Africa, Zambia, Nigeria, Uganda, Kenya, and the US. Despite this progress, there are still major gaps in PrEP availability, with only 42% of districts that have high HIV incidence having developed dedicated prevention programs. So oral PrEP, it's highly effective when it is taken as directed. High oral PrEP uptake has been seen among adolescent girls and young women in PrEP demonstration projects such as the POWER project, which saw a 94% uptake. However, adherence and persistence of PrEP still remains a challenge. A recent systematic review has looked at PrEP discontinuation and found that the overall PrEP discontinuation was 41% at month 6, and among adolescent girls and young women, this was 43%. Reasons for discontinuation of oral PrEP include individual reasons such as perceived risk of HIV infection, which as we know can change over time, side effects such as headaches, vomiting, nausea, pill burden of taking a pill every day or size, interpersonal reasons such as lack of family support, stigma and discrimination, and intermittent partner violence, structural issues which are a big challenge in low and middle income countries related to cost and access issues that are still ongoing, as well as visit burden. So there have been multiple strategies that have looked at providing both delivery options and support to overcome the challenges of oral PrEP. So the first option I'm looking at is drug-level feedback counseling. So participants who were in the VOICE trial and they conducted qualitative interviews, they reported a desire for feedback on their PrEP adherence from their drug levels during counseling. This then informed the HBT and OA2 study that looked at using dried blood spots, so a blood test, to provide drug-level feedback counseling to adolescent girls and young women. However, no effect was seen using drug-level feedback counseling on dried blood spots. Challenges with this were that with dried blood spots, there was only few labs that could do the testing, and it then took 4 to 6 weeks before they could get the results. And this is obviously challenging to provide adherence counseling to someone based on levels that are a whole month ago. Other issues were also in trying to provide the correct message, and the DBS does have a high cost of $100. So a urine point of care test, which can measure tenofovir, has been recently developed and may be able to overcome the challenges that were seen with dried blood spots. So the PrEP-SMART study, which is the graph on the right, looked at comparing the performance of the urine test to the dried blood spots. So a negative urine test was successful in identifying women who had poor adherence and who could benefit from adherence support, while a positive pregnancy test was less able to discriminate between consistent and inconsistent adherence. Drug-level feedback counseling was also found to be acceptable amongst adolescent girls and young women using the urine test, and it was easier to implement than dry blood spots. The INSIGHT study will be able to provide secondary analysis that's looking at the effectiveness of the urine point of care test on PrEP adherence, and the SCOPE-PP project will be looking at the drug-level feedback using the urine test within pregnancy and postpartum. Adherence clubs and peer support groups have also been designed to overcome some of the challenges with oral PrEP, particularly around interpersonal and the individual factors. So in the Empower study, empowerment clubs did not increase PrEP continuation among adolescent girls and young women in South Africa and Tanzania. And reasons for this was that there was lack of participation, and also it required in-person meeting and lack of social cohesion. The idea of peer support clubs were then modified to WhatsApp groups in the PrEP-SMART study. And so the PrEP SMART study looked at initial support interventions where participants were randomized to either receive WhatsApp group support or a two-way SMS from the healthcare provider. Those at month 2 who were found to have poor adherence based on their tenofovir levels were then randomized again to get additional support in the form of drug level feedback or monthly counseling. So in the PrEP SMART study, there was no difference seen between these mHealth interventions or the counseling interventions. It is likely that each strategy had similar impact on PrEP adherence, and PrEP programs should look at adopting approaches based on the preferences and the scalability of these strategies. So the 3P study has looked at incentives based on tenofovir levels to support PrEP adherence among young South African women. In this study, it was found that those in the incentive group had a non-significant higher proportion of PrEP at month 3. However, this did not persist into month 6 or 12. This finding may suggest a role of incentives. However, this would need to be stronger and with longer lasting effect on PrEP adherence. A decision support tool has been successfully used in healthcare settings to help improve client knowledge, facilitate choices, and understand risk perception. A PrEP decision support tool could help overcome some of the barriers with clients and providers to PrEP delivery, particularly in resource-constrained settings where there is limited time. So version 1 of the decision support tool has evaluated it among oral PrEP, and it was found that there was a twofold higher PrEP continuation at month 1 when using this tool, but PrEP uptake was still similar. And as we have new PrEP methods becoming available, it is important that we can be able to provide this information in a way that can inform decision making. So version 2 of the decision support tool will include the dapivirine ring and cabotegravir, and this is still pending evaluation. So these studies have highlighted that there are still challenges with oral PrEP that may be difficult to overcome, and suggest an urgent need for long-acting HIV prevention methods. But do people want long-acting HIV prevention methods? Discrete choice experiments that have been conducted in South Africa have shown that there are preferences for long-acting HIV prevention methods. So the discrete choice experiment on the left was done looking at 5 different products and among 4 different populations, and we can see that overall there was a preference for long-acting injectables. The discrete choice experiment on the right was conducted in Cape Town amongst youth, both female and males, and it found that the duration of effectiveness was the most important attribute, with a strong preference for less dosing, and injections were seen to be favored over implants. So there are a range of long-acting PrEP options that are becoming available and are still in development, and this really is a shortened list of what is really in development. The dapivirine ring is a flexible silicone ring, and it can be self-inserted monthly. And the phase 3 study showed that there was about a 30% reduction in HIV infection, and open label extension studies suggest a greater risk of reduction of around 50%. In 2021, the WHO has recommended the dapivirine ring as an additional HIV prevention option for women. The cabotegravir injection, which is provided 2 monthly intramuscularly, has also been approved and recommended. And it was shown that cabotegravir was superior over tenofovir in cisgender women in the 084 study, and HIV infection was 80% lower in the cabotegravir group. So in July of 2022, the WHO has recommended cabotegravir for HIV prevention. There have also been investigations into the use of an oral PrEP that's provided on a monthly basis, and the islatravir study was conducted in phase 2 and phase 3 trials. However, this study was discontinued as they identified that there was reduction in lymphocytes, so the white cells, in those that were in the islatravir arm. But there is a second molecule that is being investigated, the MK8527 drug, that is currently in development in phase 2 trials. So lenacapavir is a subcutaneous injection taken twice yearly and has already been approved for HIV treatment. Phase 3 trials are underway among adolescent girls and young women. So long-acting methods may not be able to overcome PrEP adherence and persistence on their own without considering integration into healthcare systems. Multiple implementation studies are underway for CAB and the depriving ring. And key implementation questions are the models of delivery, considering healthcare worker provision of and administration of injectables, HIV testing and drug resistance, particularly with the tail of cabotegravir, and also the missing data that was not around for the initial studies on adolescents, pregnant and breastfeeding women, and people on gender-affirming hormone therapy. Cost analysis, demand and preferences, and supporting choice are also important. So the HPTN-084 study, -1 study, has looked at female adolescents less than 18, and it was found that CAB was safe, tolerable, and acceptable. And in the HPTN-084 open label study, the initial results show that majority chose CAB, that was 78%, and of which there were also 15% who were on the oral PrEP initially chose the oral lead-in of CAB. In pregnant women in these studies, 68% chose CAB. So there have also been studies looking at resistance and cost, and these are modeling studies to help answer important questions. So despite increases in integrase inhibitor drug resistance, CAB is likely to reduce AIDS deaths and HIV incidence. CAB is predicted to be cost-effective if delivered at similar cost to oral PrEP with antibody-based rapid HIV testing. CAB-LA could avert 3 times more HIV infections and save 3 times more life years. Cost per CAB injection should be less than 2 times the cost of a 2-monthly supply of the oral PrEP to be cost-effective. So an acceptable range of cost per the injection has been looked at $9 to $15. So in terms of preparing for long-acting PrEP delivery, WHO has published updated guidance on differentiated and simplified PrEP prophylaxis for HIV prevention. And the 4 building blocks that it looks at is where, so that is in terms of the service location, who, as in the service provider, when, as in service frequency, and the what, as in terms of the service package. And hopefully in our discussion we can look at some of these options, because really we can have all these new products, but we need to look at how they can be delivered and accessible to adolescent girls and young women. So in conclusion, despite progress, there are still major gaps in PrEP access that still exist. A range of PrEP options are required to provide choice and increase HIV prevention coverage. Additional data is also required on populations that are not included initially in randomized controlled trials, including adolescents, pregnant and breastfeeding women, and people using gender-affirming hormone therapy. It's important to address key issues that with implementation of these new long-acting methods as they become approved. User preferences and differentiated service delivery models are important, and it's also important that we address the challenges of access and cost early in the development of new drugs. Thank you.